Welcome everyone to another lecture in GI system, which is about anatomy of stomach. But indeed, I would like first to talk about the abdominal esophagus, and then we will shift to talk about the stomach. So, um, just I would like to remind you as you know, that the digestive system composed from the gastrointestinal tract and accessory digestive organs. And we finished the mouth, we finished the pharynx, and we talked about the cervical and thoracic part of esophagus. Today we will talk about the abdominal part of esophagus and the stomach. You know that already we finished teeth and tongue, salivary glands as well. So this is the esophagus that pierces the diaphragm at the level of T10, at the level of thoracic vertebra number 10, and indeed it extends just in the abdomen for short distance, about 1.3 or up to 2 centimeters, to then join the stomach. So I would like here to remind you that yes, the esophagus pierces or penetrates the diaphragm at the level of T10, thoracic vertebra number 10, but at the same time, after 1 or 2 centimeters, it joins the stomach at the esophageogastric junction. Now, we are a little bit down. That means the esophageogastric junction at the level of T11. Thoracic vertebra number 11. So again, this is the abdominal part. You see just part of the abdominal esophagus, and let us explain, or let me show you the couple of structure or its relation to the surrounding structure. Indeed, anteriorly, it's related to the you see how the left lobe flipped up. So anteriorly, it's related to the left lobe of the liver, while posteriorly you have the left crus of the diaphragm. Where is that? Let me just erase these things and look at this is the esophagus, and this is the right crus of the diaphragm. So the right crus of the diaphragm acts as it forms like a sling around the esophagus. It's like a sphincter. Anyway, but posterior to the esophagus, once it joins the stomach, you have not the right crust, you have the left crust, right? Because this is the esophagus and the stomach as well. So anterior you have the left lobe of the liver, and posterior you have the left crust of the diaphragm. Now, once the esophagus passes from the esophageal esophageal opening in the diaphragm, it usually accompanies with a couple of structures. Most importantly, you remember the right vagus and left vagus nerves, and because of the rotation of the stomach, so the left vagus now becomes anteriorly, and we call it anterior vagal trunk. While look at the shadow in the back here, look at the shadow for the right vagus. Then because of the rotation of the stomach, now the right vagus, as you see here, is just a shadow because it's posteriorly now. So it's the posterior vagal trunk. So that means the esophagus, once it passes there, it accompanied by the anterior and posterior vagal trunk or vagal nerves, right? And also it accompanied, I will show you the left gastric vessel, the vessel that comes from the celiac trunk that will supply the abdominal part of esophagus, also with, of course, of lymphatics. So I would like to remind you that in the lower part of esophagus, as you see that the left vagus, now it's anterior vagal trunk, and the right vagus, now look, you see the shadow, it's posteriorly, it's the posterior vagal trunk. So to the blood supply of this short part, for the vascular supply of the abdominal esophagus would be from the, you see, this is the celiac trunk, which is one of the anterior branch of the abdominal aorta, in which it gives the left gastric artery that gives an esophageal branch. We call it esophageal branch of left gastric artery. So the first from left gastric artery through esophageal branch, and also you have the inferior phrenic arteries, the right and left. Here we are concerned with the left one, that also the left phrenic artery also will supply. That means the left gastric artery and left inferior phrenic artery, those indeed supply the abdominal esophagus. So that was the blood supply, that was the arterial supply. Now what about the venous drainage? The venous drainage, as you know, maybe from the previous lecture of esophagus, we mentioned that the left gastric vein, you see here is the left gastric vein, drains the lower part of the esophagus, and also, as you see here, it meets the left gastric vein, it meets the lower esophageal vein here, and they form like a plexus. So in case, or before in case, let me say that the left gastric vein drains the blood into portal vein. The portal vein is the source, or the main source, of venous drainage from the intestine, spleen, stomach, pancreas. So all the blood drained there into the portal circulation or portal vein. Then the portal vein drains it into the liver. But in case, for example, if there is obstruction in this portal vein, that means the blood will try to find a way to return, not to the liver, because ultimately we need the blood to return to the inferior vena cava, from the liver, to the inferior vena cava, and then ultimately to the heart. So what's the way to for the blood? What's the way of the blood to bypass this obstruction in the portal veins? So the way here is for the blood is to go through the left gastric vein, then from left gastric vein to the lower esophageal vein, submucosal esophageal vein, then to azygos vein, then from azygos vein to the superior vena cava, then from superior vena cava to the heart. And because of the high pressure, and because of the anastomosis formed here and the high pressure of the blood, the submucosal esophageal vein dilated. Once they dilated, look, the internal surface, this is lead to esophageal varices. Look, دوالي المريء. And sometimes it can be ruptured, as you see here, which is emergency case, need to be stopped in a way or another. So this is the blood that from left gastric here, that anastomosis with the lower esophageal veins. This is a kind of anastomosis made here called Porto-systemic anastomosis. Because that means this is the portal vein that can be obstructed here, as I mentioned, that return the blood from intestine, liver, from intestine, spleen, stomach, and pancreas to the liver, then from liver to inferior vena cava. But if there is obstruction here, the blood will be shifted to this anastomosis. Porto, that means portal, portal system, portal vein, into systemic, because that this is the systemic circulation. This anastomosis, porto-systematic or porto systemic circulation. Here's what I mean. That's achieved by the left gastric vein and the lower esophageal vein, and because of the high blood pressure there, so the submucosal esophageal, that means the blood vessels or the veins in the submucosa of the esophagus can be dilated. And look at the varices here, um, you see in those figures. So lastly, I would like to remind you that most of the time the lymphatic drainage, lymphatic vessels follow the blood supply, and we know that the abdominal aorta supplied by the celiac trunk. So we know also that we have celiac lymph nodes around the celiac artery. That means the lymphatic from the lower part of esophagus, I mean the abdominal esophagus, will be drained into the same blood supply, which is the celiac lymph nodes. So vessels, the lymphatic vessels usually follow the source of blood supply. And you know that the innervation would be for the lower part of esophagus. We have the anterior vagal trunk and posterior vagal trunk for parasympathetic, and you have also sympathetic fibers come from usually the celiac lymph nodes, the celiac plexus here. There is a kind of plexus here around the celiac artery. Okay. That's the lymphatic drainage and the innervation of the abdominal or the lower part of the esophagus, and exactly the abdominal esophagus. Okay, now let us shift a little bit, or let us continue the journey from the abdominal esophagus now to the stomach. So the abdominal esophagus joins the stomach. As you see here is look at this dilated part. This is the most dilated part of the alimentary tract, and when you look at it here, it looks like, of course, we study the empty stomach, which is like J shape, right? So where is located? The stomach usually, as you see here, it's located in the umbilical region, in the epigastric region, and in the left hypochondriac region. That means it's located, as you see here, in 3 regions. So most of the stomach you see here is like covered by the costal cartilage and ribs. So the main function of the stomach, it acts as a food blender and structure to give enzymatic digestion, and it's also works as a temporary reservoir. So that was about the location of the stomach, and we described part of its shape. So, but when you look at the stomach, we can, to like facilitate study it, we can divide it into 3 parts, into fundus, body, and pyloric part. Also, you see we have 2 borders. You have the left border represented by the greater curvature, and you have the right border, or we can call it the lesser curvature. And so we have 3 parts: fundus, body, and pyloric part, and we have lesser curvature and the greater curvature. And also we have 2 surfaces that you see here is the anterior surface, and in the back you have the posterior surface. And also you have 2 opening or 2 orifices. You have the cardiac orifice here, and you have the pyloric orifice here. So back again to if we want to get more details about the pyloric part, we mentioned that it composed from the 3 parts: fundus, body. This is the fundus, and this is the body, and this part is the pyloric part that composed or formed from three parts. The pyloric antrum. Pyloric antrum is the entrance, right? Then we have a canal smaller than the antrum, pyloric canal. That means you have pyloric antrum, pyloric canal, and you have here pyloric sphincter. Here's you have the pyloric sphincter. We'll talk about all of these parts. So let us start with the cardiac orifice. So this is the location of the cardiac orifice, in which it is the location or the site of gastroesophageal sphincter. Indeed, there is no anatomical sphincter here. That means there is no thickening in the smooth muscle to form sphincter. No, it's just the circular layer of a smooth muscle here serves as, I would say, a physiological sphincter. So it's physiological sphincter, not anatomical. There is no thickening, indeed, not anatomical like indeed, but it's physiological under the control of hormonal and vagal effect. So that means vagal nerves and hormonal secretions control the contraction and relaxation of the cardiac sphincter here, in which it's a physiological sphincter, as I mentioned. So this is the abdominal esophagus, and this is the mucous membrane of esophageal abdominal esophagus, and this is the mucous membrane of the stomach. Indeed, you cannot tell where is exactly the area between the stomach and the esophagus, because sometimes the gastric mucosa can go up or a little bit below, so it's variable. But surgeons and endoscopists usually use like this zigzag line to indicate the junction between the esophagus or between the mucous membrane or the mucosa of esophagus and the mucosa of the stomach, in which the mucosa usually of the esophagus like pale pink in color, while that in the stomach is like red and a little bit dark, right? So the zigzag line is the transitional point between the esophagus and the stomach. As you see, this is the diaphragm, and the esophagus penetrates the diaphragm at the level of T10. Now, the esophagus joins the stomach at the level of T11. That means the gastroesophageal junction here at the level of T11. But where's the, I would say, the cardiac orifice, where it's exactly, right? So say this is the midline here, and we have the, say, about the seventh, this is the for example, sorry, this is the sternum, and this is the xyphoidal process. So let us say the sixth and the seventh costal cartilage. So just 2 to 4 centimeters from to the left, of course, this is the left and this is the right. So 2 to 4 centimeters from the median plane at the posterior to the left seventh costal cartilage is the, say, the location of the cardiac orifice at the level of T11. So yes, we mentioned the part of the stomach, our fundus, body, and pyloric part. So the fundus, as you see, it's the dome. It's like a dome shape located to the left of the cardiac orifice. So say this is the right and this is the left, so it's to the left of cardiac orifice. And usually, because it's the highest part, because it's the dome, so gases, as you know, naturally, normally go up and accumulate here. And the gases or air in the lungs, for example, they are it's black. And also, look at, this is the shadow of the heart, and this is the right dome of the diaphragm, which is a little bit higher than the left dome of the diaphragm. So this is the diaphragm here. So this is the say the fundus of the stomach, and here is the say the shadow here of the liver, right? Anyway, so look at the gas here. Look at the gas here in the, which is the plaque under the left of diaphragm. This is a gas bubble in the fundus of the stomach here, right? So in X-ray. So yes, I explained that the diaphragm here shows dome shaped shadow on each side, on the right and on the left, and the right dome a little bit higher, I think 2 centimeters, around 2 centimeters higher than the left one. And look at the homogeneous dense shadow of the liver on the right, while you have a kind of air bubble like spot, black spot here, which is indicates a gas in the fundus of the stomach under the left dome, right? So that was the fundus. And what about the body? Very simple. The body, which is the largest part, as you see, and it extends from the level of the cardiac, say this is the level of cardiac orifice, so it extended from the level of cardiac orifice all the way until you reach this point, which is the beginning of the pyloric part, in which, look at this angle, we call it angular insurgira, angular insurgira, or you can say angular incisura, angular incisura, like British or American pronunciation. So this is the angular incisura, or what we call it angular insurgira, in the lower part of the lesser curvature, right, which is constant there. Now, yes, we mentioned that we have two borders. You have the lesser curvature and you have the greater curvature. Let us start with the smaller one, which is the lesser curvature, that extends or forms the right border of the stomach and extends from the cardiac orifice to the pylorus. When you say pylorus, that means you indicate to this part, you see this constriction, right? So this is the pylorus, whereas the sphincter is here. So this is the pylorus. You can say pylorus or pyloric sphincter, right? So it's suspended, the lesser curvature you see here, suspended to the hilum of the liver by the lesser omentum. And if you need to know more about lesser omentum, you can watch or read the lecture of the peritoneum, right? But let us say this is a double layer of peritoneum connected the lesser curvature of the stomach and the first part of the duodenum here. So it connects the lesser curvature of the stomach and the first part of the duodenum to the hilum of the liver. And you know, it composes from two parts, membranous part, and you have the ligamentous part. So the ligamentous part connects the first part of the duodenum to the liver. We call it hepatoduodenal ligament, and this one is hepatogastric ligament. Both we call them lesser omentum. So now jump to the greater curvature of the stomach, that it is longer than the lesser one and extends from the left of cardiac orifice over the dome of the fundus, as you see here, then along the left border of the stomach all the way until you reach again the pylorus, right? So also, if you need to know more about the greater curvature, you can watch the lecture of peritoneum and greater curvature. But anyway, you know, the greater curvature connects the stomach to different structures and it composed from different parts. So the greater curvature connected to the surrounding structure by greater omentum. This part of yellow color double layer of peritoneum, we call it greater omentum, not lesser omentum, greater omentum, in which it has three parts. One, that it started from here, like ligament connects the fundus of the stomach to the diaphragm. We call it gastrophrenic ligament. And you have another one, look at the spleen here. So you have gastrosplenic ligament, and look at the transverse column here that connects the wrist part to the stomach here. So this is the gastrocolic ligament. All of these form the greater omentum, not lesser omentum. Lesser omentum connects the lesser curvature. Greater omentum connects the greater curvature of the stomach to the surrounding structures. Again, this is the greater curvature you see here. And let us now, we finished the fundus and the body. Let us move to the pyloric part. So pyloric part, my friends, which is like a funnel shape, in which is the outflow region of the stomach. So the chyme that digested here should pass through the pyloric part. So the pylorus, my friends, or the pyloric part has three parts. So, or three structures, let us say. The first part, which is the pyloric antrum, that, this is the widest part. This is the entrance. This is the pyloric antrum that leads into a narrower canal. We call it pyloric canal. This is the pyloric canal. Then you jump now to a really marked, thickened circular layer of smooth muscle. You see the smooth muscles here, like thickened to form a sphincter. We call it pyloric or pyloric sphincter. So this sphincter is the pyloric sphincter. I will show you after a couple of slides. And this opening is the pyloric orifice. The opening itself, the orifice, but the thickening of smooth muscle forming the sphincter called pyloric sphincter. But this is the orifice, right? Pyloric orifice. So that guarded, of course, or controls the discharge of the stomach content to the duodenum. So the pylorus, my friends, located at a level known as pyloric plane, at the level of L1. How can we now? You can, if you need to know more about the division of the abdomen, you can watch the lecture about the anterior abdominal wall and how can we divide it. But for now, look at the stomach. Here is the shadow of the stomach, and this is the pyloric part. So that's, at this level, there are a couple of structures. There is a lecture about transpyloric plane. There's a short video, 10 minutes, about transpyloric plane. You can watch it. But anyway, this is the transpyloric plane. There is a plane passes through the pylorus. And indeed, how can I determine where is that? Just, it's the located midpoint between jugular notch and symphysis pubis. So the midpoint is here. Or you can say it's a midpoint between xiphoid process and umbilicus. Again, it is the midway. So this is the transpyloric plane, or the way to determine exactly where is that. So this is a view. You look into the pyloric sphincter from this side. So what you see is here. Look at the pyloric sphincter and pyloric orifice. And this is the duodenum, of course, here. Look at the gastric, in the interior of the gastric here. Look at the folding of gastric mucosa here, right? So look at the stomach. Look at the mucosa of the stomach. It's formed like mucosal folds like ridges. We call them, so when the stomach contracted, the mucosa here is thrown to longitudinal ridges. Look at these ridges. We call them wrinkles, and most probably we call them gastric folds or gastric rugae. Gastric folds or gastric rugae. They are mostly can like obvious when you go close to the let us say the side of a greater curvature and toward the pyloric part. So they are prominent here and less prominent in the fundus and close to the lesser curvature. But anyway, look at the lesser curvature here and close to it here inside the stomach. There is something called gastric canal. This area is we call it a gastric canal, which is like a canal formed between the longitudinal gastric folds along the lesser curvature, in which it can be observed radiographically and during the endoscopy of the upper endoscopy of the stomach. So in the gastric, I would say gastric canal, or what we call it Magen or Magenstrasse. Here is the Magenstrasse. I will tell you what does it mean. This is German name, Magenstrasse. Anyway, the gastric, here is the location of the gastric canal, is important because once the food destroyed and becomes like a fluid, or in the case of the saliva and you drink a fluid, or the chyme is ready to move to the duodenum, it passes here through the gastric canal and it drains through this canal to the pyloric part, then to the duodenum as well. And so the saliva and a small quantity of masticated food and other fluid drains and along the gastric canal to the pyloric canal when stomach is mostly empty, right? So indeed, the gastric canal is the common or frequent site for the peptic ulcer, right? It's a common site so let me tell you what's the gastric canal or Magenstrasse it means. Magen, that means stomach, right? It means stomach. But Strasse in German, it means road or street. Strasse, that means street. So that means the gastric canal is the street of the stomach, right? Now, what about the relations of stomach? So we have mainly the anterior, most importantly, the anterior relation and the posterior relation of the stomach. Starting with the anterior relation, look at this part that exposed, this part of the stomach that exposed, you see here. So you know that the anterior abdominal wall removed. That means anteriorly, we have the anterior abdominal wall removed. And also, once you remove the anterior abdominal wall, that means there was costal, the left costal margin, and here cartilage as well. So you have the anterior abdominal wall, you have the left costal margin here, and of course you have the diaphragm as you see here, and here is the location of the left lung that covered by pleura. So that means anterior abdominal wall, left costal margin, diaphragm, left pleura and lung, and you see here the left lobe of the liver. This is the liver and this is the left lobe of the liver. These are structures anterior to the stomach. But let us remove the stomach. Let us cut it. This is the part of the stomach that just connected to the abdominal esophagus. So this is the stomach should be extended to here, all the way like that until just connected to the duodenum. So what's the posterior relation? The posterior of the stomach. The posterior relation of the stomach, we call it clinically the stomach bed, which is really very important. Why? because there are many structures there, and in case if there is a cancer in the stomach, the only solution for the stomach is the gastrectomy, to remove the stomach and to merely remove a couple of structures behind the stomach. So for example, in this case, the structures related posterior to the stomach are, let us start from here. This is the left dome of the diaphragm. This is number one. And you have the upper part of, look at the left kidney. So behind the stomach, you have the upper part mainly of the left kidney and the left suprarenal gland. What else? You have the spleen, and you have the splenic artery. And now we reach to the pancreas. This is the pancreas. And also it's related to transverse column. This is the shadow of the transverse column partially, right? And you know that behind the stomach, we have the lesser sac. The space behind the stomach, we call it lesser sac. You can watch the lecture of peritoneum to understand what's the lesser sac. But simply, lesser sac is a space that's located behind the stomach. So these structures called the stomach bed. So let us reflect the stomach. This is the stomach reflected by a hook up to have a look posterior. This space here, you see, is the lesser sac. This is number one. You see the left dome of the diaphragm. Posterior to it, you have the spleen, you have the left kidney or upper part of left kidney and left suprarenal gland. You have again the spleen, you have the splenic artery and and you have the pancreas. You see the shadow of the pancreas, which is retroperitoneal structure. You have the transverse colon. So because look, we cut it from here, right? And yes, the lesser sac, the space that's located here. All of these things are located behind the stomach, and we call them the stomach bed. Now, finally, we have to shift now to the blood supply of the stomach. Very simple. You know the anterior branch of the abdominal aorta, which is that known as celiac trunk, or sometimes they call celiac artery, but I prefer to use celiac trunk because it's larger than artery. Anyway, so let us start this from this side, then we'll move to that side. So from the celiac trunk itself, there is a small artery here that known as left gastric artery. So this is the left gastric artery that passes along the upper border of the lesser omentum until it reaches the upper part of the lesser curvature. Then it divides to supply the lower third of the esophagus and also to supply the upper part of the stomach, and you see here on the lesser curvature. Also, it's united with the not the left gastric, with the right gastric. This is the left gastric, comes from celiac trunk itself, but right gastric now, it comes from the hepatic artery, which is a branch of celiac trunk. So this is the celiac trunk, this is the hepatic artery, and from hepatic artery you have the right gastric that of course supplies the lower right part of the stomach. That means the lesser curvature supplied by two parts, the left gastric artery up and the right gastric below. Okay, now you know this is the splenic artery passes behind the stomach, which is a branch again of celiac trunk. So this is the splenic artery behind the stomach to supply the spleen, but also from splenic artery you have blood supply to the fundus of the stomach, which is, we call them short gastric. You remember the left gastric and the right gastric? So no, we have here short gastric because they are short to supply the fundus of the stomach. Also, from the spleen artery, from the splenic artery, sorry, you have not just short gastric, you have the blood supply to the part of a greater curvature, which is we call it left gastroepiploic artery. So yes, we finished the short gastric arteries, branch of splenic artery, and we forgot to mention, you know, that the spleen connected to stomach by part of a greater omentum, a ligament called the gastrosplenic, a ligament between the stomach and spleen, gastrosplenic ligament. So these arteries, short gastric arteries pass through the gastrosplenic ligament. Now, again, from the splenic artery, we have a branch here down to supply the upper part of a greater curvature. This is the greater curvature. This is the upper part of a greater curvature, right? That's supplied by lift, because you know this is the left side of your body and this is the right side. So this is called left gastroepiploic artery, but also we call it sometimes left gastro-omental, which is similar to the epiploic foramen and omental foramen. Epiploic and mental the same, right? You can say, or you can read in textbooks like left gastroepiploic and also left gastro-omental artery. Okay, if this is the left gastroepiploic artery, comes from the celiac. What about the rest part of the greater curvature? Yes, it's supplied by the same name, but right gastroepiploic, not left, right gastroepiploic artery, but it's a branch of gastroduodenal artery. Yes, gastroduodenal artery is a branch that passes behind the first part of the duodenum, which is very important. It's at risk to be ruptured, and you get a risk for bleeding in case perforated because of peptic ulcer, right, or duodenal ulcer. Anyway, it passes behind the first part of duodenum. It comes from hepatic artery that comes from celiac trunk. That means the blood supply ultimately comes from the celiac trunk. So celiac trunk, hepatic artery that gives the gastroduodenal artery, passes behind the first part of duodenum, then it gives the right gastroepiploic artery. That means the right gastroepiploic comes from an artery different than the left. The left comes from splenic artery, but the right comes from gastroduodenal, that comes from hepatic artery, right? Okay. Here is another like a view, the liver reflected up, and this is the celiac trunk that gives the left gastric artery to supply the lower part of the esophagus and the upper part of lesser curvature, right? And the left gastric united with the right gastric artery that comes from hepatic artery. Anyway, here is like we finished the lesser curvature. Now come to the, look at the, again, celiac trunk that gives a splenic artery, passes behind the stomach until it reaches the spleen, but it gives from there the short gastric artery, passes in the gastrosplenic ligament. And also the splenic artery gives the left gastro-omental artery that passes in the layers of greater omentum, or in the layers of gastrocolic ligament. This is the gastrocolic ligament, or you can say greater omentum, that's fine. And also this is the left gastro-omental or gastroepiploic. You have the right gastroepiploic here. This is the right gastroepiploic that to supply the right side of a greater curvature, but anyway, or the lower part, comes from the gastroduodenal artery that comes from the hepatic artery again. So this is from a cadaver. You see the lower part of esophagus, and this is the stomach. This is the fundus and the body. Then you have the incisura angularis here and the pyloric part. But anyway, you see here's the abdominal aorta and the celiac trunk here that gives couple of branches. One of them is the left gastric artery, right? and also you have the right gastric artery here, of course, posterior to it. You have the splenic artery that passes to the spleen that gives short gastric artery, and left gastro-omental or gastroepiploic artery passes on the upper or the left side of the crater curvature, and you have here the not the left, you have the right gastro epiploic or gastro-omental artery that comes from the gastroduodenal artery that comes from hepatic artery, right? So that was about the arterial supply, but what about the venous drainage? The venous drainage of the stomach is very easy. You know that the blood from the stomach returned ultimately to the portal vein that of course drained into the liver to be then transmitted, detoxify, you know, they have blood with like minerals and different structures should be manipulated in the liver, then drained into inferior vena cava. Anyway, so the blood drainage ultimately to the portal circulation, but in this case, let us explain a little bit, which is very easy. The left gastric vein, which is accompanying the or compared to the left gastric artery. So you have left gastric vein and right gastric vein. Those drain directly into the portal vein itself, right? Okay, let us jump here now. You remember the short gastric artery, but here we have short gastric vein. The short gastric vein, it drains into splenic vein, and also the left gastro-omental or left gastroepiploic also drain into splenic vein. So this is the splenic vein behind the stomach. Okay, it receives blood from inferior mesenteric vein. Let us continue. And let us stop here. Behind the neck of the pancreas, you see the shadow of the pancreas. So this is the neck behind the neck of the pancreas. This is the head of pancreas, the neck of the pancreas, and body and tail. But anyway, yes, we said that the left gastro-omental or gastroepiploic and short gastric vein, they drain into splenic vein. But now the right gastro-omental, it drains into superior mesenteric vein, and now the superior mesenteric vein superior mesenteric vein and splenic vein, they S and S united behind the neck of the pancreas to form the portal vein that drains into the liver. So always remember that S with S, that means splenic vein united with superior mesenteric vein, not inferior. Inferior mesenteric vein just drains blood into splenic vein, right? But who's forming the portal vein? The portal vein, let me erase it. So the portal vein here formed by the union of splenic vein and superior mesenteric vein behind the neck of pancreas. Okay, and that means ultimately to the portal vein. Now, what about the lymph drainage? Lymphatic drainage is important. Why? Because if there is a cancer, that means the mucosa and submucosa. Let me remind you that the mucosa and submucosa of the stomach are connected by lymphatic vessels. That means any tumor or cancer in the stomach in anywhere, say here or there, can be transmitted to anywhere in the stomach. But there is a general idea to memorize the lymph nodes and lymphatics in the stomach. So usually all lymph of the, let us say in general, you know, the blood supply of stomach comes from celiac artery, and there are nodes around the celiac artery, and we know that lymphatic vessels and nodes usually follow the arteries, and we know already the blood supply of stomach, they come from celiac trunk, and we know the names of different arteries: short gastric artery, right gastric artery, left gastric artery, left gastric, right gastric, short gastric, left gastroepiploic, right gastroepiploic, gastroduodenal, and ultimately they are a branch of celiac trunk. And here the same for lymph nodes. You have, let me change the color. So you have left gastric nodes, you have right gastric nodes, you have short gastric nodes, you have splenic nodes, splenic artery, remember? You have splenic nodes here, with here, and you have left gastro epiploic nodes, you have right gastroepiploic nodes, you have gastroduodenal nodes, and most importantly, you have gastric lymph nodes. All of these will drain into the celiac node or celiac lymph nodes. Celiac lymph nodes, lymph nodes around the celiac trunk. Okay. Before jumping to the clinical part, let me remind you with the nerve supply of the stomach. If you study the esophagus, it's easy to know that we have anterior vagal trunk, that was the left vagus nerve, and you have posterior vagal trunk, that was the right vagus nerve. But because of the rotation of the stomach 90 degrees clockwise, now the left vagus becomes anterior vagal trunk. So the anterior surface of the, of course, you have the innervation of the stomach, you have sympathetic and parasympathetic. Before talking about the sympathetic, let me talk about the parasympathetic, in which the parasympathetic comes from vagus nerve, right? Both vagi, they carry parasympathetic fibers. So the parasympathetic fibers, they are important because they increase the motility and the secretion, like when you are really relaxed, right? So when you are relaxed, so your stomach and even the mobility of your intestine increased and the secretion increased, you become like hungry and you want to eat and so forth. So anyway, for the parasympathetic fiber, you have the anterior surface of the stomach, of course, innervated by anterior vagal trunk. The vagus nerve carry the parasympathetic fibers, and we talk about the anterior surface of stomach. That means the anterior vagal trunk. Look at it here. It gives also hepatic branch to the liver, and from this hepatic branch, there is a branch come out from there to the pylorus, right? Branch to pylorus. Okay, now what about the posterior surface of the stomach? Also, the parasympathetic fibers reach the posterior surface of the stomach. Look, dotted line, that means I'm talking about the posterior stuff in the back, posterior vagal trunk, that of course innervates the posterior surface of the stomach, and it gives off not hepatic branch, no, it gives off a larger branch to the celiac plexus. Here you see this plexus, and below it here there is another plexus for superior mesenteric artery. Whereas there is artery, there is a plexus around it. Here is celiac artery, celiac plexus, superior mesenteric artery, superior mesenteric plexus. That was about parasympathetic fibers carried by vagus nerves, anterior vagal trunk and posterior vagal trunk. But what about the sympathetic fibers? Okay, sympathetic fibers, indeed, the function of it's opposite to the parasympathetic. That means when you are under stress, or you fear from something, or you fight, or whatever, you fought somebody, but in this case, you don't feel that you are hungry. So what will happen, that the sympathetic is antiperistaltic, has antiperistaltic function, and it also creates a kind of a vasoconstriction. So it's not the time of eating and secretion and motility. No, it's opposite to the parasympathetic. Anyway, this is the function of sympathetic. So they derive the sympathetic fiber from the celiac plexus. You see this kind of celiac plexus here. So it gives like fiber to it. Somebody can say, yes, this plexus formed by parasympathetic and sympathetic. Parasympathetic from vagus nerve, but the sympathetic comes from where? It comes from the spinal cord segment from T6 up to T9. From there is fiber, sympathetic trunk here, go, of course, through the greater splanchnic nerve and distributed through the plexus around the gastric and gastrointestinal arteries. Okay, so cancer in the stomach, this is the problem, especially when you know that we have many structures behind it, and you know that the lymphatic vessels of mucous membrane and some mucus, submucosa in the stomach are in continuity. So as I mentioned earlier, cancer here or there can be transmitted to anywhere through the lymphatic vessels network there in the stomach. So the only way mainly is to do what we call it total gastrectomy, remove the stomach at all. So what they remove the stomach, they remove the lower part of esophagus, and they remove, as I mentioned, the stomach, and they remove the first part of duodenum, right? First part of duodenum also they remove it. They remove the spleen, and here let us show it to you. So they remove the spleen and splenic vessels, veins and artery, and they remove the pancreas that's located here, and they remove the lymph nodes along the greater curvature and lesser curvature, and also what else? Remove lower part of the esophagus, duodenum, splenic. Okay, splenic vessels, duodenum. Yes, and the spleen, not the whole of spleen. You see here, I didn't draw the head. So the head of pancreas will be preserved mainly as much as possible because it's located, it's highly vascularized, and it's located in the curve of duodenum. So they remove just the body and tail because there are also like bile duct here, and there is a blood vessels up and down with the duodenum. So it can be very difficult. So these structures that mainly represent the stomach bed. Okay, now jump into the hiatal hernia. What's the hiatal hernia? It's like a herniation of part of the stomach into the up into the thorax, right? Through the diaphragm. So a protrusion of part of the stomach superiorly into the mediastinum of the thorax. We call it hiatal hernia. So افتاق المعدة يعني. So the hiatal hernia has two types, mainly that we see anatomically. So we have the paraesophageal and we have a sliding type. So start with the paraesophageal, in which look at the esophagus here and look at the cardia. We forgot to say that the cardia, then when you say cardia, it means the area around the gastric orifice or cardiac orifice. You know, this is the cardiac orifice, so the region around it, we call it cardia around, so the region around cardiac orifice. Anyway, look at the cardia. It's still in its place. That means cardia remains in its normal position, but look at the fundus of the stomach, part of the fundus of the stomach that surrounded by peritoneum. This is the peritoneum, right? So part of the peritoneum and part of the fundus here, like moved up into the thorax. But look at it, the cardia. That means it's normally in its position. That means the sphincter here, the physiological sphincter, will not be affected. That means you will not, there will be usually no regurgitation of gastric content up, right? Because the cardiac orifice, it is in its normal position, right? There will be no GERD or acidity usually, or no regurgitation. But look at the sliding sliding hiatal hernia, in which it's like what you see here is that like the abdominal part of esophagus that covered by peritoneum here um, is like moved up, and the cardia as well. So abdominal part of esophagus and the cardia, both, and part of course of the fundus, all of these structures, the abdominal part, cardia and fundus, all move sliding up into the into the um, into the thorax. And in this case, that means the cardiac orifice, it's not in the place. This is the location of cardiac orifice. This is the zigzag line. That means it's not functioning very well. It's weak. And also the effect of right crust of the diaphragm around the esophagus is like the effect of it is weak. That means you have to expect a kind of regurgitation of gastric content up, like food and acidity, so something called like that was known as GERD, right? So this is the paraesophageal part, and this is the sliding, the paraesophageal hiatal hernia and sliding hiatal hernia. This is a kind of herniated portion of the stomach. This is the esophagus, and this is a hiated portion of the stomach. This is the again the shadow of the stomach distal to the diaphragm, right? It should be the location of the diaphragm. We have a congenital anomaly seen especially in babies, in which this is the pylorus, and this is the we can say pyloric sphincter or pylorus. And look at the thickening of the smooth muscle. They are thickened beyond the normal, something called hypertrophy. Hypertrophy is the thickening of the smooth muscle in the pylorus. In babies, it leads to pyloric stenosis, in which there is a kind of elongated, overgrown pylorus, and it's hard. That means the stomach cannot really empties its content into the duodenum. They cannot pass through the pyloric orifice here because of the thickening of smooth muscle there. So this is called congenital hypertrophic pyloric stenosis. And the most sign of this congenital anomaly is the projectile vomiting. So that's after feeding. Once the baby gets the meal, sorry, then the result will be a projectile vomiting, called projectile vomiting because the vomiting like will be projected at least, let us not say at least, but it's for half or a meter or so. So that's why I call the projectile vomiting. Then after vomiting directly, there is a persistent hunger. That means the baby cry because he or she wants to eat soon after the vomiting, because nothing passed into the intestine. So that was about the abdominal esophagus and the anatomy of the stomach. Hope you find value in it. Thank you.